Who gets FMT? Who doesn't? When can foot mobilisation be most effective? When could it be most harmful? For goodness sake, where's the research? A recent literature review conducted by Aaron Woolahan, PhD candidate at QUT in Brisbane, he identified 29 articles on foot and ankle mobilisation, dating from 2000 to 2014. These articles overwhelmingly confirm the therapeutic benefits gained from mobilisation of the foot and ankle. While the literature supports the use of foot mobilisation techniques, FMT, as a therapeutic tool, we need to remember that FMT is not a panacea or a silver bullet for every condition. In fact, there are some conditions where FMT can cause harm or damage. This video tutorial will outline the key categories every practitioner using mobilisation treatments must consider before implementing FMT as a treatment option. These three categories are: 1. The indications, 2. The contraindications, and 3. The precautions. This is really important to appreciate because we must be very careful in our patient selection process to make sure that we help rather than hinder our patient's progress. So let's begin first of all with the indications of FMT. FMT is a modality to use on musculoskeletal conditions of the foot and leg. The global objective of FMT is to release connective tissue restrictions that interfere with normal joint function. Interference of normal joint function causes connective tissues around the joints to compensate, and it's this compensation that leads to the symptoms our patients complain of. So the first category to use when considering FMT as a treatment option is musculoskeletal symptoms such as heel pain, ankle pain, subtalar joint pain, talonavicular pain, mid-tarsal pain, forefoot pains, and digital pains. Remember to differentiate non-mechanical joint dysfunction symptoms. For example, if you have a patient with a painful, inflamed first MP joint, mechanical joint dysfunction would be hallux limitus or osteoarthritis of the joint. A non-mechanical dysfunction would be gout, which has a chemical etiology, not a mechanical one. Make sense? Great. The second category to use when considering FMT as a treatment option is to consider the biomechanical status of the feet. Irrespective of what assessment method you're using, you're looking for biomechanical compensations. A foot posture index will score highly. Gait analysis will show joints functioning abnormally, usually at their end of range positions. Pressure plate analysis will highlight uneven loads through the foot. So whatever assessment method you use, if you see abnormal degrees of subtalar and or mid-tarsal pronation, these are indicators for connective tissue restrictions. The third category to use when considering FMT as a treatment option is the specific joint range and quality of motion. It's very important to be able to differentiate normal range and quality of motion from a restricted or limited range of motion. Palpating joints and assessing joint range and quality of motion is a very important skill in mastering FMT. In fact, we've dedicated a whole lesson in this training to help you develop your palpation skills quickly and effectively. It's coming up in lesson 6. It's a very important skill for a practitioner using manual therapies to be able to feel the healthy range of joints compared to limited range of motion. And if you can't do this effectively, then as a practitioner, you're going to be behind the 8 ball. So to summarize, the 3 key indications for using FMT are: 1. Musculoskeletal symptoms of connective tissues, 2. Biomechanical compensations, and 3. Limited range of motion of the joint or joints. Now, let's move on to the contraindications. The first crucial contraindication is a suspected fracture. What are the clinical signs of a fracture? Well, it's a localized area of pain which is swollen, inflamed, and painful to touch. If you have a patient present with these clinical signs, assume it's a fracture until proven otherwise. X-rays will conclude this for certain, and X-rays are the best diagnostic tool for determining the presence of a fracture. Remember to pay attention to your patient's clinical history. If there's been any recent physical event that could have caused or contributed to a fracture, it's important to know. That's a key question to ask. It's just so important you don't try to mobilize a joint where there may be a fracture. One of my wise mentors said to me, "Ted, make sure you don't create a joint where there's not supposed to be a joint." Wise words indeed. The next contraindication is hypermobility. FMT increases joint motion. If the patient's joints are too mobile, the last thing they need is more mobility. These patients need stability and muscle strengthening. So how do we know if a patient is hypermobile or whether it's just isolated joints that have increased their range of motion? Well, we do the Baton flexibility test. You're probably already aware of this test, but if not, we've included it in our downloads that's available in this training. Using this flexibility scale, if your patient measures 4 or less, FMT should be fine. If they measure 5 or 6, I'd be cautious about which techniques were used on which joints. If they scored 7, 8 or 9, FMT is out. The next contraindication is joint coalition. If joints fused, no amount of FMT is going to change that or the affected joint or joints. This includes post-op joints which have been surgically fused. The next contraindication is bony blocks. Now, sometimes the unique anatomical shape of joints causes a bone-on-bone end range position. If this is the case, FMT isn't going to change that, so no go here. The last contraindication for FMT is the presence of osteochondral lesions. This is where there's damage to the articular surface. It's like the cartilage has blistered and shows up clinically with the following signs. There's a history of single traumatic injury or repeated trauma to the ankle. Symptomatically, there's prolonged pain and swelling, even after periods of rest. And is there catching or instability of the ankle? It's an important thing to determine. If your patient reports any of these clinical signs, an MR image might be required to confirm diagnosis. So to summarise the key FMT contraindications: 1, suspected fracture; 2, hypermobile joints; 3, joint coalitions; 4, bony blocks; and 5, osteochondral lesions. The next category will require your greatest interpretive clinical skills. This is the list of precautions you must consider. First up is an acute sprain or inflamed joint. FMT can play a really valuable role in treating sprains, like an ankle sprain. If you're going to mobilise acute sprains, you better listen to your patients and work within their tolerance level only. Next precaution is the patient who has peripheral vascular disease. You've got to make sure that you're not going to further complicate or harm your patient if they have a history of DVTs, or if they're on blood thinning medication, or if they bruise easily. You'll also need to exercise caution with long-term type 1 diabetics who have a compromised vascular status. You assess this on a case-by-case basis. I'm a type 1 diabetic, my vascular status is excellent, but your next diabetic patient may not be so fortunate. Next is the patient's pain threshold. Now, pain thresholds can vary wildly. You need to work within the patient's tolerance level, and that may mean reducing the level of force that you use. The next precaution, it's actually for you, the practitioner. And that is, if your patient has any fungal or wart conditions, wear gloves. This is to protect you from infection. And finally, I need to comment on the advice given in the Orthopaedic Manual of Physical Therapy. And that is, high velocity thrust techniques should only be performed by those with sufficient clinical experience. Well, how the heck are you going to get sufficient clinical experience without actually performing high velocity techniques? Well, that's a conundrum. The answer is to undertake training with an experienced facilitator who has 20+ years of experience to draw on and who has an excellent record in helping students achieve competency in FMT. So, to summarise, the precautions for FMT are: 1, acute sprains; 2, peripheral vascular disease; 3, pain threshold; 4, fungal conditions or warts; and 5, your FMT experience level. So there you have a comprehensive summary of the indications, contraindications and precautions of using FMT to get better clinical results for your patients. In the next lesson, I'm going to dive into the FMT protocol that's proven itself to be the most effective in hundreds of clinics all around the world. We're going to cover the what, the why, the how, so that you have the most comprehensive understanding of how to use FMT in treating MSK conditions of the lower limb. It's gonna rock. Until then, serve with spirit, consult with care, and help more people today. In the next lesson, we'll dive into the most effective mobilisation techniques to free up stuck cuboids. This is where you get your hands on feet to use a highly effective treatment option for cuboid-related problems. This is an invaluable skill that's revolutionised how cuboids are treated all around the world. Until then, serve with spirit, consult with care, and help more cuboids today. not a panacea or a silver bullet for every condition. In fact, there are some conditions where FMT can cause harm or damage. This video tutorial will outline the key categories every practitioner using mobilisation treatments must consider before implementing FMT as a treatment option. These three categories are: 1. The indications, 2. The contraindications, and 3. Who gets FMT? Who doesn't? When can foot mobilisation be most effective? When could it be most harmful? For goodness sake, where's the research? A recent literature review conducted by Aaron Woolahan, PhD candidate, the precautions. This is really important to appreciate because we must be very careful in our patient selection process to make sure that we help rather than hinder our patient's progress. So let's begin first of all with the indications of FMT. FMT is a modality to use on musculoskeletal conditions of the foot and leg. The global objective of FMT is to release connective tissue restrictions that interfere with normal joint function. Interference of normal joint function causes connective tissues around the joints to compensate, and it's this compensation that leads to the symptoms our patients complain of. So the first category to use when considering FMT as a treatment option is musculoskeletal symptoms such as heel pain, ankle pain, subtalar at QUT in Brisbane. He identified 29 articles on foot and ankle mobilisation dating from 2000 to 2014. These articles overwhelmingly confirm the therapeutic benefits gained from mobilisation of the foot and ankle. While the literature supports the use of foot mobilisation techniques, FMT, as a therapeutic tool, we need to remember that FMT is